Welcome again to the Procedural Safety, Module 4. My name is Irina Yudin, and on behalf of the MDRN Collaborative, we will spend our time during this tutorial talking about chest tube placements. Chest tubes, also called trocars, chest drains, thoracic catheters, tube thoracotomies, or intercostal drains, are nothing more than a plastic tube inserted into the chest wall, to the pleural space or to the mediastinum. It is used to remove air or fluid from the intrathoracic space, to restore or optimize lung function. There are a host of descriptive names for these conditions which represent the indications for a chest tube placement. Let's go down the list. Pneumothorax, or air in the pleural space. Hemothorax is a blood in a pleural space. Hemopneumothorax is a combination of air and blood trapped in a pleural space. Tension pneumothorax is air under pressure in the intrathoracic space. Thoracotomy or open chest surgery could be an indication for a chest tube. Cryothorax is lymphatic drainage in a pleural space. Emphyema is purulent fluid in the pleural space. And hydrothorax, which is serous, non-inflammatory fluid located in the pleural space. Some of these conditions develop slowly over time, with subtle clinical changes, while others can occur abruptly and present as medical emergencies. The first 4 items on the list are more likely to cause a medical emergency. If there is any delay in care, it can result in a cardiac arrest and death. With that in mind, let's take our time to review the pre-procedure care. First was the focus on what equipment you will need. This is really important because your first line response in an emergency is to call thoracic surgery and make sure you have a credentialed provider on the way. They will arrive in minutes and you must have all the equipment at the bedside. Get another RN or CP involved. Here is what you will need. First, the procedure card. Everything the surgeon needs to get started is on the card. Second, get a PleurVac, suction containers, tubing and sterile water. Get them all from the clean utility room. The thoracic suction head is available in each ICU room. It is labeled as such, and what differentiates this from the other suction heads is that it has a limit of 60 millimeters of mercury pressure. Having said that, the amount of suction pressure applied to the chest tube site is determined by the amount of centimeters of water in the suction chamber. Third, get lidocaine from the Pyxis. Now that you have everything you need to set up and support placement of the chest tube, someone should be on hand to support the surgeon during the procedure while the other is setting up the equipment. Whenever possible, consider sedating your patient. Make sure the consent is completed. In times of emergency, it is most important not to delay care. In times like this, one physician emergency consent is appropriate. Once the procedure is complete and the patient is settled, take a minute to make sure the proceduralist has completed his note as a part of their documentation in the patient's chart. Also check in to be sure the family has been contacted and the residents have considered calling their attending and patient's primary doctor. In a less emergent setting, go to the pre-procedure care list and take time to provide teaching and support to the patient and family during the consent process. Evaluate the need for sedation with the medical doctor and prepare medication as needed. It is important to obtain a chest X-ray and arterial blood gases after intervention to confirm placement of the chest tube and adequate oxygenation and ventilation. Okay, now that you have gone through and completed your pre-procedure care, it is time to focus on the procedure itself. The first consideration is sterility. All clinicians in the room should have clean hands, hair cap, face mask, and gloves. The proceduralist will have a sterile gown and gloves while maintaining a sterile field and technique throughout the procedure. Make sure the procedure cart is closed at hand and your pleurovac is set up and functional before the procedure begins. The chest tube kit has thoracic clamps for the proceduralists. But you wanted to make sure that as long as your patient has a chest tube in place, that you have 2 clamps at the bedside at all times. If for any reason the chest tube gets disconnected from the closed drainage system, you will want to clamp the chest tube to prevent air from entering the pleural space until you can reconnect the pleurovac system. Monitor vital signs during the procedure and communicate this information to the proceduralists as needed. Apply occlusive dressing post-procedure and secure tubing. Post-procedure care includes obtaining a chest X-ray to confirm chest tube placement. Consider arterial blood gas as needed to evaluate oxygenation and ventilation. Make sure all connectors are secure and thoracic suction is on at the prescribed centimeters of water. This is routinely set at 20. There should be a gentle rolling bubble in a suction control chamber. An ongoing monitoring of the patient once the chest tube is in place includes vital signs. Observe for changes in baseline or instability. Chest tube output. The frequency of monitoring chest tube output varies depending on your patient's condition and the volume of output. It ranges from Q15 minutes to once a shift. But in general terms, once the chest tube is placed, monitoring should be frequent, every 15 minutes monitoring, to make sure that the patient is not having large volume losses, like over 100 cc's per hour, which is often associated with hemodynamic instability. In cases where there is a brisk output, 1-to-1 volume resuscitation may be ordered. So for every milliliter lost in the chest drainage, there is 1 ml in IV replacement. This is just a general rule for supportive care, not during hypotensive crisis. Monitor pain. Chest tubes are painful, and patients should have pain-relieving medications ordered to support their comfort. Monitor for tidling in a water seal chamber. This indicates that a negative pressure has been restored in the chest, and fluctuation in thoracic pressures are evident. Monitor for air leaks in a water seal chamber. It is normal to have air leak on insertion, especially when relieving a pneumothorax. Once the air has escaped and the seal is obtained, the air leak will often stop. Observe for crepitus. This is air trapping in subcutaneous tissue and is most often result of poor chest tube placement or diseased, poor healing tissue. Air escapes around the chest tube and rises up to subcu tissue. Positive pressure ventilation can accelerate this problem. Observe for hemostasis or clotting in the chest tube. This may present a sudden or slow reduction of chest tube output and or redevelopment of the pathological condition, pneumothorax, for example. Here are just a couple of reminders of what you can expect when managing your patient with a chest tube. As just mentioned, it is normal to see bubbling in a water seal chamber after the chest tube placement. Keep an eye on this over time, and you should see a reduction or elimination of this as air removed from the pleural space and a seal around the chest tube is achieved. Bubbling with exhalation and coughing is normal. Persistent bubbling indicates a leak in a patient's lung or chest drainage system. Avoid fluid-filled loops in the tubing as it decreases the effectiveness of the suction. Now let's go over some do's and don'ts for the chest tube care. Let's start with do's. Check the water level in a suction control chamber every shift. Do this just by pinching the tubing to stop the rolling bubble and make sure that the water level is at the prescribed suction amount, typically 20 centimeters. If not, Just top it off. This is important as water will evaporate over time, and the more vigorous the bubbling in a chamber, the faster it evaporates. If the level drops, you will have a reduction in applied suction. Check the water level in the water seal chamber every shift as well to ensure an adequate seal. It should always be at 2 centimeters. This level ensures that the one-way valve of seal preventing the patient from being able to suck air into the pleural space and maintaining negative pressure in the lungs. Do position the pleurovac below the level of chest. This facilitates drainage, keeping the tubing from filling with fluid and reducing suction pressure. Do change the pleurovac when its draining chamber reaches 2000 mL. Now the don'ts for the chest tube care. Don't strip or milk the tubing. It can cause excessive negative pressure. Don't clamp or kick thoracic tubing. Always transport patients on a water seal. Clamping puts excessive pressure on the site and in worst case scenario can cause a pneumothorax. Don't coil tubing as it limits drainage. And don't forget to check for titling to ensure patency of the thoracic catheter. When supporting the placement of a chest tubes, clinicians need to be prepared for an emergency. While most placements are uncomplicated, when procedure is complicated, the results can be dire. Let's review the complications. Some of the complications include hemorrhage and shock, increased respiratory distress, infection, damage to the intercostal nerve, incorrect tube placement that can result in unresolved clinical issues or further compromise one, subcutaneous emphysema, loss of integrity of the chest tube by the way of kinking, clogging, or dislodgement. This concludes Module 4 on a chest tube placement. Thank you for listening.